We're talking to Dr. Rupesh Kotecha with the Miami Cancer Institute, which is part of the Baptist Health South Florida system. And we're talking about the new age of personalized radiotherapy. Thank you so much for being here. Thank you for coming to the Cayman Islands and sharing your expertise with everyone here.
Well, thanks for having me. This is my first time here and it's been absolutely wonderful.
Good, we hope you come back then too. When we talk about personalized radiotherapy, that sounds a little, I would have never seen that coming, I guess. So can you tell me a little bit about what that means in terms of, how you're able to actually create something that is specific for a patient's needs?
That's a great question. So now we're really entering an area of cancer care where we personalize treatment options for every patient based on their specific risk factors, their specific characteristics, potentially any mutations they may have in their cancer, and really the extent of their disease. And when people think about personalized cancer care, they traditionally think about medical oncology. There may be certain mutations in their cancer, and then they could receive a targeted drug for their specific cancer and a specific molecular alteration in their tumor. However, in radiation oncology, we've made similar types of advances. And although we don't treat patients based on specific mutations or molecular alterations, that information is actually essential for how we make decisions in radiation oncology. And they could be as simple as we should combine forms of radiation with some targeted agents. Potentially, if patients progress on targeted therapy, instead of changing to a different type of targeted therapy, we can actually just radiate that area that's growing past that molecular alteration, and that patient can actually stay on that targeted therapy. And then finally, we can actually personalize the actual type of radiation that we give to a patient. So radiation therapy is traditionally a black box, and unfortunately patients may not know what type of radiation they're getting. We use different particles of radiation to actually treat patients. Historically, there were electrons and photons, but now we have different types of particles, for example, protons. So we're able to offer proton therapy for a variety of patients. But even if I just said, this type of radiation, photon therapy, is available for a majority of patients that are treated either in the islands or in the US or across the world, all types of photon therapy are really not the same. There's a variety of radiation technologies that are available to treat cancer patients. And when a patient is newly diagnosed with a certain type of tumor, they traditionally see a radiation oncologist and they're told, okay, this is what you have, this is the type of radiation that you need. We will scan you tomorrow and then you will start on Monday. However, the actual type of radiation that the patient may receive, they may not know. And it may not be personalized to them. It may be based on the only machine that's available at that cancer center, and the patient's not given that information. Contrary to that, at our cancer center, we're very fortunate in that we have basically one of every single machine they make in radiation oncology. So when I see a cancer patient, I'm able to make a personalized decision for that patient and choose that machine which is actually best for them based on all of those factors. Any mutations, patient characteristics, risk factors, and disease extent. And therefore, I'm able to offer that patient the best form of therapy for that particular patient. And it may differ from the very next patient that I see in clinic that may be very similar, but actually has specific differences in which I have to choose a different machine for that patient.
So I think one of the things that you mentioned is, you get the diagnosis, we're going to scan, we're going to start radiation. There's a lot of information, I think, coming at someone who receives a cancer diagnosis. It can be intimidating, overwhelming, you feel the need to just trust your doctor and do what they say. How can a patient be their own advocate? What questions should they ask? What things should they be aware of?
That's a great question. Whenever you're diagnosed with a cancer, the first thing that you should do is make sure that your case is presented at a multidisciplinary tumor conference. Okay? This is something that we do for a majority of patients that are seen at our cancer center. And this helps to ensure that the patient is treated on a specific care path or pathway that is based on that patient's disease extent and based on the current standard of care for that patient and potentially any clinical trials that may be offered for that patient. So for example, I primarily specialize in brain cancer and in lung cancer. So when we have a patient who's newly diagnosed with, for example, a stage 3 lung cancer, that's very overwhelming for the patient. You hear stage 1, stage 2, stage 3, and stage 4. And everybody knows that stage 4 disease is where you don't want to be. And if you are at stage 3, that's very concerning to you. You know that's close to 4. Well, there's a variety of treatment options for patients who have stage 3 lung cancer. You could sometimes get chemotherapy followed by surgery, and then maybe radiation therapy afterwards. Some patients get chemotherapy and radiation and then go to surgery. Some patients get surgery first and then get chemotherapy and radiation afterwards. And some patients get chemotherapy and radiation together and then potentially get immunotherapy afterwards. So you can think about, those are just 4 essential treatment options for a patient, and that can be very overwhelming. So the first thing that we do is we make sure that we review all of that patient information, all of their images, and together as a group, with multiple radiation oncologists, with multiple surgeons, with multiple medical oncologists, even social workers, even the nurses that see the patient, all of those people are involved in the decision making for that patient, so that we can make sure that we make the best decision for that patient and that we have all of the information available with all of the minds at our cancer center to be able to offer that patient a treatment option for them.
So me as a patient, I would say, who are you talking to, and who's looking at my file with you?
Correct.
Right?
Correct. So, when I see a patient who's newly diagnosed, they've either seen the medical oncologist or the surgeon first, or sometimes I see them first. So I make sure that the patient is told that we have looked at your images together. This is a group decision. I'm not making this decision unilaterally. In fact, outside of the multidisciplinary setting, at our cancer center, in radiation oncology, we also have an ongoing peer review for every single patient. So if I decide this is what I would like to treat the patient with, I've talked to the entire cancer team. All of my information, my radiation treatment plan, the target volume delineation, what dose and fractionation that I decide for the patient, how many treatments they're going to get, over what length of a period of time, all that information is actually peer reviewed by other radiation oncologists in our own system. So that's also very unique to how we practice radiation oncology at our center. So there's multidisciplinary with regards to surgeons, medical oncologists, and radiation oncologists, and kind of an in-house multidisciplinary care in radiation oncology.
Okay, so you want, as a patient, you want to know that that's what's happening with your case.
Correct.
Interestingly, shift gears just a little bit. You were talking about, there's surgery and chemo. These are the things we hear: surgery, chemotherapy, radiation therapy. Now, with some early stage lung cancer, radiation therapy can actually be curative.
That's correct. So with radiation oncology, we have, as a field, made tremendous advancements in technology. And that's allowed us to really expand the use of radiation therapy. Now, traditionally, when you hear about radiation therapy for early stage lung cancer, it was for patients who would never have surgery, would never even see a surgeon for their diagnosis because they were such compromised by their pulmonary function. However, we're now expanding the use of radiation therapy in those patients. And because traditionally, people thought the cure rates, the control rates were exceedingly low compared to surgery, typically 30 or 40 or 50%. Those results are honestly terrible. And that's why radiation therapy was really a last resort for patients with early stage lung cancer. With evolving technology, we're now able to offer definitive and curative radiation therapy for early stage lung cancer in 5 treatments, 4 treatments, 3 treatments, or sometimes as short as 1 treatment. Radiation therapy, when we give it in this sense, is termed stereotactic body radiation therapy or stereotactic ablative radiotherapy. Sometimes the population will hear the terms SBRT or SABR. Those types of radiation techniques are very different from the older forms of radiation therapy. It would almost be comparing an old type of surgery where we do a midline thoracotomy and then actually take out a tumor versus sometimes a robotic or laparoscopic surgery. It's very different types of radiation. They're very precisely delivered just to the area of the tumor. And really we minimize the dose of radiation to the surrounding structures, such as the rest of the lung or even the heart or the esophagus. By doing that type of very precise radiation, we can give very high doses of radiation that are ablative, and like I said, as short as 1 treatment of radiation, which is non-invasive. The patient does not see anything, they do not hear anything, they do not feel anything. The machine doesn't touch them at any point. They're typically on the machine for as short as 15 minutes, maybe as long as 40, 45 minutes, and a few treatments later, they're potentially controlled or cured from their early stage lung cancer. There's no incision, There's no hospitalization at all required.
That's such an amazing difference in terms of the treatment and the outcomes. Now, you mentioned earlier proton therapy, which sounds very science fiction, but how has that changed things?
Proton therapy is really the most advanced form of radiation therapy that we're able to deliver. Now, traditionally, as I mentioned, electrons or photons, they're just particles of radiation. And what we're trying to do is maximize the dose of radiation in the tumor and minimize the dose of radiation in the surrounding structures that are next to the tumor. Now, we've evolved over time to make it as precise as we can, but we're very limited to how we can do that with photon therapy. Proton therapy, as you said, sounds science fiction-y. And it's actually delivered in our center using a large cyclotron that then sends proton particles at very high energies to very large radiation machines that then deliver those proton particles to a patient's tumor. What's really exciting for us is that proton therapy allows us to deliver radiation just to a tumor and to really minimize the dose of radiation to a nearby sensitive structure as much as possible. This then allows us to give a very high dose or curative dose of radiation to the tumor, but the minimal amount of dose to that nearby sensitive structure that can cause a side effect associated with the radiation, both acute, short-term, during the radiation, shortly after the radiation, but even long-term, many years after the radiation is completed.
All right. Well, I think there's a lot of good news now coming from this area of oncology. Thank you so much for sharing with us, and thank you for your time here in the Cayman Islands. Don't forget to ask those questions of your specialists, and make sure that there is a holistic approach to your care. I think those are some really important messages that you've shared with us.
They are. Thank you for recapping those.
Thank you.